Hello. All right. I think we are just about the 12:05 and we have a nice showing, so we can go ahead and get started. Welcome everyone to this week's a special in-person hybrid Zoom Grand Rounds. We are very fortunate to be joined by Sean Agbor from the NIH, along with his fellow that works with him in his lab, Ashley Park, who will be featured in the talk. To talk to us about cell-free DNA to detect disease and organ involvement early. To provide some background about Sean, Dr. Sean Agbor-Enoh completed medical school at the University of Yaounde, Cameroon, and a PhD in post-doctoral training in molecular biology at Georgetown University. He then pursued residency at Johns Hopkins, where he was also chief resident. His joint clinical fellowship training was in pulmonary and critical care medicine at Hopkins and the NIH. He joined NHLBI as a staff clinician and is now a tenure track investigator through the Lasker Clinical Research Fellowship and NIH Distinguished Scholars Programs. He is chief of the Laboratory of Applied Precision Omics. Dr. Agbor's research mission is to improve transplant survival by developing better approaches to detect and effectively treat transplant rejection. I should mention that's among many research missions. We're fortunate to have him talk about that one. So thanks again, Dr. Agbor, and the floor is yours.
Thank you, really, thank you for that kind introduction. And really, thank you for the very warm entertainment. As you know, one of my very first fellows, Sam Brisker, left the NIH and came here. Indeed, we kept a position for him to come back. It seems like over the years, he wasn't coming back. And I was wondering, why is Sam not coming back? I mean, such a reception that I received yesterday. There's no doubt in my mind that why Sam didn't come back. I'll go back and tell Henry Mazur that maybe Sam is not coming back. We should move on from that point. And, you know, I'm also going to try to highlight Ashley Park today in one of the presentations. You know, as we do this and as we train ourselves and train fellows, it really starts becoming how important the work that fellows do towards the research mission. And so I thought it would be important for one of the fellows, Ashley Park, who've done work that is in this space as well, to give a presentation as well. So Ashley is going to talk also after this, or somewhere in the middle of my talk. So I don't have any significant disclosures, but there's one that I would give to you is that I'm very biased, and I'm very biased towards transplant. And we can say, oh, well, that's normal. No, I don't think so, because the way you think about the disease influences the research questions you ask. That's not unbiased. There's some bias to that. The science is not completely an unbiased field. So I'd like to give that disclosure, even though ACGME does not require that we say, oh, we love the science we do as a bias. It does that. But think about transplantation in that sense, that in my mind, it is truly, truly a remarkable branch of medicine. If you think about it, someone is going to unfortunately die. Existing therapies, whether it's devices, electrophysiological approaches, medications, they cannot help it. They cannot help that person or her. You take out that lung or heart and you put a new one, and this person can live again, a second chance of life. I don't know if that doesn't blow your mind. What does? So I'm biased, right? I think transplant is so cool. It's not even funny, right? Allow me to, let me leave this story to give you a little bit of glimpse into the beauty of transplantation. All right.
think it'd be positive the sound to work again.
Yeah, the sound works before. Oh, the sound is blocked. How do you unblock the sound? Yeah. We have our IT person left.
It may have.
Let's see. If it doesn't, it's good. Okay.
Sorry.
Well, so I would let the story run for itself, and then hopefully you sometimes pictures speak 1,000 words. And so maybe we would enjoy the video, and then hopefully we can talk a little bit about it. So I'll give you a glimpse so you could follow it. It's a woman whose son was hit in a car accident, and she donated her son's heart for heart transplantation. And the heart got put into this young man who is now 20-something years old, John Hochstein. And John Hochstein had a congenital heart trouble and needed a heart transplant. So this woman agreed for her son's heart to be put into John Hochstein. And 20-something years later, she could listen to her son's heart still beating in John Hochstein. And this, John is currently at Stanford, finishing his fellowship in thoracic surgery. So it's just some beauty of transplantation, if you may. And so you could almost guess where that bias comes from. Now, the story is not always glorious with transplant, right? It's not always a John Hochstein story where the patient does so well and starts having really near normal life. Because you put this organ in an immunologically hostile host. That host, unfortunately, has immunity. And that organ can undergo rejection, which could be antibody-mediated, acute cellular, or a composite of both. At least this is the way we currently think of it now. However, for the lung, and sometimes for the heart, you could also have infections. That milieu of infection plus rejection truly creates an environment where there's a near constant inflammation in this allograft in some patients. And within only 5, 6, 7 years of transplantation, 50% of lung transplant patients would have died or lost that lung from complications related to rejection or infection. For heart transplant, it's a little longer, somewhere around 15 to 20 years. But as you know, if you transplant someone in their 30s and 40s, someone in their 30s and 40s, they still have 30 to 40 years of life in them. If they are only living about 15 years after heart transplant, it's better than they were gonna die, but we could do better. So in thoracic organ transplant, both heart and lung much more than heart, the outcomes could be made better. And the primarily rejection, which is a major risk factor for allograft loss, often starts clinically silent. And so in both heart and lung transplant, we do the following. This is a lung transplant physician like John Greenland that you guys know here. They usually get this is a bronchoscope. It's a long cable with a camera in front. You put that through somebody's nose and mouth. You go down their lung and you take bits and pieces of it to send for histopathology. Heart transplant, they go through the IJ, the internal jugular vein. They go with a catheter down into the heart and they take small pieces of it as endomyocardial biopsies. The same concept. At Johns Hopkins, where my clinical practice is This is the frequency that we do surveillance bronchoscopy plus biopsies in patients to look for early stages of rejection. As you can imagine, this is an invasive procedure and has many problems. Heart transplantation is actually a little bit more, because these patients can get 15 to up to 30 biopsies in the first 2 years of transplantation alone. Moreover, when you get the biopsy tissue and you send it for histopathology, histopathology too has its own problem, such that this approach can often miss rejection or detect it at late stages when treatment is often ineffective. We really need to do a better job. And it turns out transplantation itself could offer a potential solution in getting better diagnostics, because transplantation does something. It creates genomic admixture, means that organ is coming from a different person with a different DNA, and you put it in a recipient. So in that transplant recipient, you now have a mixture of two genomes. It's a unique medical scenario that you don't find in many other disease models. But could you then take advantage of things such as cell-free DNA? You could also use proteomic-based approaches, but could you look at things like cell-free DNA, things that would be secreted from that allograft into the circulation to infer what is happening in the allograft? We chose the option of cell-free DNA, but you could choose anything. You could do cell-free RNA, you could do proteins, you could do many different things to infer what is coming out from that allograft. Cell-free DNA are short DNA fragments that are released into the circulation when cells die. They're quite abundant. Hold that concept in your mind a little bit. These are short fragments of DNA coming from all over your body into the circulation when cells die. Therefore, if I could just grab a little bit of plasma from a patient, I could infer not only what is happening to the allograft, I may be able to infer what is happening in every tissue across the body, right? It comes with that degree of precision, and hope I'll convince you of that. So in a transplant patient, therefore, this lung is coming from a different person. If I take plasma from that patient, I have here represented here in red cell-free DNA from the recipient, and in green cell-free DNA from the donor. And I can choose my method: shotgun sequencing, digital droplet PCR, targeted sequencing, easily quantitate the fraction of donor-derived or allograft-derived cell-free DNA as a marker of transplant rejection. So we developed the method. We actually Steve Quick from Stanford developed the initial first generation assay, and I traveled to his lab in my early fellowship years to learn that from his lab. It was kind of him to accept, and then we came there and did that. The next thing we did is we created a consortium, because the NIH does not have a transplant program. So created a consortium of transplant centers to recruit patients and monitor them serially after transplantation. To date, we have about 720 lung transplant patients. It's a very elaborate team of clinical research infrastructure that the NHLBI provides, with protocol navigators, nurses, that without them, this cannot work. The infrastructure that this clinical research needs, it's amazing. So we're very fortunate to be at a place where the institution understands that, and they put in a lot of effort with people that are really dedicated to get this to work. And so within about 5 or so years, we could have 700 and something patients with greater than 150,000 vials of biosample. Right? So I was talking to Connor, and Connor, within a few months, the guy's already at 100 and something patients. I'm like, how are you doing this? We took 5 years and we're barely even started. And so, building clinical infrastructure is hard. So people who could do it, man, I respect that a lot. And we've been fortunate to have some people out there. And I think people like Connor and others are beginning to develop that kind of infrastructure here as well. What we also opted to do was to invite some people that we know really do rigorous clinical research from across the country and in the world, in Europe as well. UPenn, Stanford, UCSF with John Greenland, with over there and Leuven, to expand this cohort towards more than 1,000 lung transplant patients. So that effort is funded by the Cystic Fibrosis Foundation, and it's ongoing. Does it work? I think hopefully I will convince you that it does. On the y-axis here is the fraction of donor-derived cell-free DNA, and the x-axis is time. It's a single patient here. Cell-free DNA is low. This patient got acute cellular rejection, it's high. This patient got treated this time well, it comes down. In red is cell-free DNA that was done in my lab at the NIH, and in blue, done at Stanford in Steve Quick's lab. The assay by shotgun sequencing is very reproducible. However, this is where I think the money is. If you imagine time zero is the time that the biopsy says the patient have rejection, or the patient shows any clinical signs of rejection, the cell-free DNA is high. However, 2 to 4 months, think about it for a minute, 2 to 4 months before that biopsy shows signs, particularly for antibody-mediated rejection, or before the patient shows clinical signs, you have increase in cell-free DNA. We've shown that in both heart and lung transplant patients. Early detection of rejection. What could we do if we could find out that the patient has signs of rejection and treat them 2 to 4 months earlier? Would that make a difference in the patient? That's an open question to be answered. However, the test is also non-specific. It can tell you when there's something wrong in the allograft because it's a SNP-based assay. It's relying on simple nucleotide polymorphisms. So anytime there's injury in that organ, the test becomes positive. Maybe you have an infection or you have rejection, the test becomes positive. It is not specific. However, such a test could be an ideal monitoring tool. An ideal monitoring tool to tell you that something is wrong or not wrong, and then you can either then use that information. COVID-19 provided an opportunity for us to test that in routine clinical care in patients. What we proposed, and the FDA gave us through CareDx, which is a company not too far from you guys here. The CareDx, the company then worked with the FDA to get compassionate use approval for the test. We proposed to do monthly cell-free DNA in lung transplant patients. So the patient gets their first biopsy after transplant at month 1. After that, no more biopsies. They get cell-free DNA instead. If the levels are low, in lung transplant it's less than 0.5. In heart transplant it's less than 0.2. Think about the order of magnitude, right? This gives you an all-clear signal, especially if PFTs and other things are low. The patient is fine, you leave the patient home. Indeed, we hired phlebotomists to go into patients' houses to draw the test during the pandemic. You don't want immunosuppressed patients out in the street to get blood draws, so we hired people to go to their houses. If the levels are somewhere in the middle range, you watch the patient more carefully. If the levels are high, greater than 1%, that's the alarm signal or the danger signal. You bring the patient in the hospital, do a series of tests, including biopsy, find out what is wrong and treat the patient. If you don't see anything wrong, monitor the patient. Because remember, cell-free DNA levels rises early before patients develop symptoms, biopsy evidence. So we proposed this, did this, and we were able to show that using cell-free DNA to monitor patients instead of biopsy is safe, and you avoided 80% of biopsies. And several lung transplant centers are now using this approach to monitor their patients, which was not what we intended in the first place, because the study we proposed was to do a randomized control study, cell-free DNA against standard of care. But then COVID-19 came, and we showed that this is safe. People start using it. The company felt it's not worth, people are using their test anyway. Why are they going to pay for an RCT? So everybody pulled their money away. And now people are using the test, but without the clinical evidence of its utility. It's safe, yes. We have all the cohort study data that would suggest that it could be useful, but otherwise, that's about it. So, however, remember this test that I showed you is sensitive. I'll go back to the next slide, but it's not specific. We've learned a few things using that test. It can pick up rejection and it can pick it up early. It can detect severity of rejection, which predicts long-term outcome. And that could be used as a safe alternative to biopsy. And it predicts long-term outcomes in patients. However, the test is not specific. We needed a test. So if your test is positive, you still need to bring the patient in the hospital to do biopsies and all that. And I showed you the limitations of biopsies. Could we develop a specific test? And hopefully, this is the second principle that I would like to leave you with. The first was that the cell-free DNA, it's released from every area in your body into your circulation. And so you can sample that to almost figure out what's going on in different parts of your body. But the second is an important basic science principle. If you think about disease for a minute, let's take this case, acute cellular rejection and antibody-mediated rejection. There's a reason that we define these things as disease. There are two reasons, many reasons, but let's take two for now. The first is that the cell types that are involved in that disease is different from one disease to another. That's the first thing. If you take acute cellular rejection, you have lymphocytes. Antibody-mediated rejection, you start with a neutrophilic infiltration in the cardiac myocyte. Number two, if you look at acute cellular rejection, the insult is within the heart parenchyma itself. Antibody-mediated rejection starts as a vasculitis. So the cell types and the tissue types that are involved are different. First principle. Second principle, the molecular mechanism that leading to disease, or what we call the pathobiology, is distinct from one disease to another. Therefore, the cell types that are producing cell-free DNA are different, number one. Number two, the biological pathway leading to the production of cell-free DNA is different. If you have those two concepts in mind, we know that DNA rules, right? Ruler of the cell, DNA. You know, when we were in undergrad, that's what they used to do. DNA rules. DNA tells the cell what to do and when to do it. So all those phenomena are packaged within DNA and they're secreted in cell-free DNA. That may be more specific. If you think about DNA, your DNA sequence in your entire body is identical, more or less. No, there's no 100% in medicine, we know that. But more or less, it's identical. Means the DNA sequence from your brain, from your heart, from your liver, from your kidney, they're identical, but yet the heart spends all day beating. The lung breathes and gives you oxygen, the liver does metabolism, the intestines absorb. How can the same DNA sequence orchestrate such different function in different organs? The answer is that on top of DNA, or the way DNA is packaged, there are these Christmas lights called epigenetic fingerprints that confer DNA tissue specificity. Means that DNA from the liver have features that are distinct from DNA from anywhere else in the body. Concept number two. Now, those epigenetic tissue-specific or pathway-specific epigenetic fingerprints are preserved on cell-free DNA when it leaves the cell into blood. Therefore, if I now take cell-free DNA, I don't sequence it, but I scan it for epigenetic fingerprints. Could I identify molecular or the tissue types that are involved in disease? Could I identify the biological pathways that are involved in disease by scanning the epigenetic fingerprints? I hope I could convince you that the answer to that is yes. So I've been very fortunate. The second thing, great clinical infrastructure provided at the NIH. The second thing that I've been very fortunate are just wonderful basic scientists. I have this guy, Moon, Gang, I think Sam was my very first fellow, Sam Busker. Sam will tell you stories about Moon. Moon is a true basic scientist at heart. And this guy sits and thinks about cell-free DNA in ways that sometimes astound me, trying to bring biological processes into diagnostics. And he's developed a series of diagnostic cell-free DNA approaches. I was talking to the fellows, we just help translate that into clinical medicine. What does this cell-free DNA approaches? How could you use this clinically? The two that I'll highlight here is looking at cell DNA methylation, or what we call CF methylome, or CF ChIP-seq, looking at chromatin immunoprecipitation approaches. As you know, there are tissue-specific genes, troponins only made in the heart, AST, ALT from the liver, a little bit from the muscle, and then you can go on and on. Every tissue types have tissue-specific genes, and you can target that to look at tissue-specific signatures. In this approach, you would take cell-free DNA, you take plasma from a patient. Notice now that this plasma have multiple colors to represent different tissue types. We isolate this using an automated platform. We can quantitate the cell-free DNA using whatever approach you choose. We work with Bio-Rad to develop digital droplet PCR platforms, so we use that. You can sequence that now by scanning the epigenetic fingerprints. You can do DNA methylation by bisulfite sequencing. You can do chromatin immunoprecipitation sequencing, or you can do your pick. And if you have a library of tissue-specific signatures, all you need to do is to survey your sequence reads for those tissue-specific signatures to identify the tissue sources of cell-free DNA and infer their molecular pathways. But let me convince you that that's correct. I'm going to show you 4 patients with COVID-19. My x-axis is the amount of cell-free DNA. So my y-axis is the amount of cell-free DNA, and x-axis is time from hospitalization. These are patients with COVID-19 who died. They came on day 0 of admission. We collected serial blood samples over time. You measure their cell-free DNA is high, 1,000 to 1,500. We looked at extremes here. Healthy controls have about 10 to 20 nanograms of cell-free DNA. It's 1,000. COVID is a bad disease. The cell-free DNA reduces over time, overall. Between day 10 and day 14, they go into an inflammatory phase of COVID, accompanied by an exponential rise in cell-free DNA, until, unfortunately, these patients died. The key to your right, this is the first generation assay, 25 different tissue types that we could pick up. Now we are somewhere around 42, 50 something tissue types. The different colors represent the different tissues producing cell-free DNA at different times over that course. Compare that to patients with COVID-19 who survived their index hospitalization. The amount of cell-free DNA at admission is different, 600 to 650, looking at extremes. The trends of cell-free DNA over time is different. I was talking to one of your colleagues telling me about he wants to ablate some patients who have AFib. Like, you want to figure out what's happening to tissue injury? Collect serial samples. The key is serial in this case, and you can find the trends of different tissue over time. You could see this in these patients. The trends are different. The tissue types are different. The amount is different over time. These are the tissue types that the first generation assay could measure, but now it's much more than that. We've gone forth to show that, yes, you can do this in multiple disease syndrome, not transplant. Take it we've looked at it in 7 disease types, and it works. This is multi-system inflammatory syndrome in children, which is this multi-system inflammatory disease that kids develop after they develop COVID. Thomas Gern, a postdoc in the lab, just published this in, it just came out. We've done this at patients in advanced heart failure. Ashley is going to talk a little bit about that. Graft versus host disease, pulmonary hypertension. I don't know if you guys recognize that name. That's Sam Busker. And allow me to highlight that study for a minute. And then we come back to transplant. Sam did this work. My slide didn't come out well because his picture was supposed to be here. So imagine there's a picture here, And that picture here is Sam Burska. I'm sure you guys know him. It's that guy over there. So he was my first fellow in the lab, and he set a precedent which I really would like to highlight. This guy came and did the pipetting in the lab himself, right? Very diligent, and he was very good at it. So he looked at pulmonary hypertension, and this paper was published in Circulation. He looked at patients. As you go with different degree of severity, you have a stepwise increase in your total cell-free DNA. This is a log scale here in nanogram per ml. You could see, right? Say now we are in copies per ml of cell-free DNA. You can tell when some was in the lab, right? When nanograms per ml, it's like the first generation, I say. We are now generation 4. So it's been a little bit of time. So as it tracks with disease severity in pulmonary hypertension, but more importantly, it can predict transplant-free survival. Patients with high cell-free DNA, they go on to die or require transplantation at much higher rates compared to patients with lower cell-free DNA. He published that paper. He was able to show distinct tissue sources of cell-free DNA based on pulmonary arterial hypertension disease severity. You could see if I block this here, these are healthy controls. These are patients with more severe disease. You can see the color change is not subtle. So he was able to define the tissue sources of injury in these patients with pulmonary hypertension. And I think it is this figure that really allowed him to publish the paper in Circulation. And the NIH did a press release when he did that. This was a figure that the NIH made. When the NIH sent that out, 40 news outlets picked that up. It was really cited really well. It got a lot of press. Again, imagine Sam's picture is supposed to be here. I don't know what happened to my slide. I missed it. But I thought I'd highlight that work from him, because we've also gone to then pick that technology up, develop it a little bit more, and show it in these different disease phenotypes that I just talked about. Allow me to stop here. And I'm going to ask Ashley to present a little bit now. Ashley Park is a fellow in the lab, critical care medicine from the NIH, is going to be applying to cardiology this coming year, and will talk to us a little bit about cell-free DNA in patients who've received LVAD. I'll stop here. Ashley, can I stop here? And you tell me what to do. I can do next whenever you're ready.
Okay, sounds good. Thank you, Sean, for the opportunity. So like Sean said, I'll be talking about this technology in the LVAD population. Sean has already given you some background into the diagnostic value of cell-free DNA in these various populations. And I'll touch a little bit on how we can use cell-free DNA to mark and track therapy in different populations, but specifically in LVAD. Next. So part of the scope of the problem here is that we know that we have some life-saving therapies, including mechanical circulatory support, and these can be life-saving for patients with advanced heart failure. Next. But it's really challenging thus far to figure out which patients will do well and which patients will do poorly. Sean, you can do the next two. And so some of the questions that we've tried to address in our lab are, one, does LVAD offload tissue injury, and if so, from which organs? And then two, does cell-free DNA predict clinical outcomes in LVAD patients? And so a little bit about how we got started. So this is just a schematic of that graft collaboration that Sean was describing earlier. So it's a multi-institutional collaboration across multiple centers looking at cell-free DNA in the heart and lung transplant population. And so what we have is, I focused in on the heart transplant group, and we have, Sean, next, plasma collected serially from before transplant and serially after. And what we do is we analyze the cell-free DNA from all this plasma, and it gives us insight into what is going on. Now, today I'll focus a bit on the pre-transplant collection. And so this is just to highlight the group that has advanced heart failure who are listed for transplant but haven't yet received one. Next. And so when we look at this group as a whole, we had 235 patients in total. I have log2 nuclear cell-free DNA on the y-axis, healthy controls are in blue, heart failure patients are in red. And if we compare the two, we see that heart failure patients had much higher levels of cell-free DNA compared to healthy controls. And this suggests that there is a greater degree of cellular injury happening in heart failure patients compared to healthy controls. Next slide. And when we look at markers of disease severity and track cell-free DNA accordingly, so I'm using the old allocation system of 1A, 1B, and 2 on the x-axis here, we see that the patients who are at the highest priority, and therefore theoretically the sickest patients, had the highest levels of cell-free DNA compared to the other groups. Next. So if the question is, well, where are these, where's the injury happening? Where do we see this? And so like Sean said, we can use the technology that's available in our lab. So usually methylation markers. So we can use the epigenetic patterns on the cell-free DNA itself to give us insight into where the injury is happening. Next. This is a busy graph, and it's a selection of different tissue subtypes from that deconvolution algorithm that Sean was describing earlier. And I have heart, innate immune cells, kidney, liver, lung, and vascular endothelium on the x-axis here. And you can see that probably obviously heart and vascular endothelial cells seem to have more tissue injury compared to healthy controls in the heart failure population. But what is probably most striking is that innate immune cells have the highest levels of cell-free DNA, suggesting that heart failure is an immune active process, and that there is pathophysiologic insight that we can gain from cell-free DNA. And then Sean, just pause here, and just to get the scope of, it is not just a disease of heart, innate immune cells, and vascular endothelium, but we see it in all these different organs that heart failure seems to have tissue injury occurring at multiple levels compared to healthy controls. Next. Now moving on to the LVAD population. So this is now, we're going to disregard the healthy control group, and we're only looking at advanced heart failure patients and looking if they had LVAD or if they didn't have LVAD. So if we compare those who didn't have LVAD in blue to those who did have LVAD in red, we see that there was a decrease in the levels of cell-free DNA. And this was in contrast to what we had seen in some of our other subgroup analyses. Like, for example, when we looked at patients with ECMO, they had higher levels of cell-free DNA. Patients with inotropes had higher levels of cell-free DNA, suggestive that there's more cell injury happening in these populations. However, in the LVAD population, we saw something that was different. And so we hypothesized that this was related to the offloading of the heart. Next. We wanted to take a closer look at this population and based off what we had seen in that advanced heart failure cohort. And so what we did is we designed a separate supplemental study taking just LVAD patients and looked at their pre-LVAD levels and compared it to their post levels. Next. And when we look at their values, we see that it's very similar to what we saw in that other cohort I described earlier, where after LVAD, you had lower levels of cell-free DNA, so indicating that you had lower levels of tissue injury. Next. If we look a little bit more granularly here and we look at individual patients, now we have individual patients are marked as dots. The lines are connecting their pre-values to their post-values. We see that, as expected, most patients have decreasing levels of cell-free DNA. But there are some who had unchanging levels, some who had increasing levels. And one of the natural follow-up questions that we had was, does any of this matter? Which piece of this matters in terms of clinical outcomes? So when we look at their pre-values, does that matter? Does it matter if they change, or does it matter what their post-values are? So I'll focus in on the pre-VAD values first. Next. And if we look at these pre-VAD values and apply it to a Cox regression model looking at time to mortality, we see that nuclear cell-free DNA is predictive of time to death when you adjust for LVAD indication. And here, LVAD indication means that you are on, you received the LVAD because you were getting destination therapy, or if this was a bridge to transplant. So that is so far what we've done with the mortality or the Cox regression models. Our next steps are to look at those percent changes. So just to summarize what we've learned so far, number one, cell-free DNA levels reduce after you implant an LVAD. Number two, pre-LVAD cell-free DNA levels may be predictive of time to survival. And but our work is not done, and we have a few extra steps, and we're hoping to validate some of our hypotheses in more complicated regression models, and then two, identify the tissue injury profiles of these patients. And with that, I'll turn it back over to Sean.
Okay. Now, Ashley, thank you very much. I was talking to Connor, like, Connor, we really gotta find a validation cohort out here. You guys are doing so much work. And so I think Connor is trying to put in an IRB to get that. You guys may know Chris as well. Chris was ahead of me in our fellowship program. So it seems like a tight net. So hopefully we can find a validation cohort for Ashley to not only validate this, but then take it a step further, right? I think there's some insights to this. And if you think about it, in a sense, expand that a little concept is actually, in my mind, there's a core principle here. How do you monitor treatment? If you look here, some patients got LVAD. Their cell-free DNA were not the same when they started, and the trends of their cell-free DNA was not the same. Now she will look at the tissue injury. How do different tissues respond to treatment? And could you use that trend over time to define better phenotypes of treatment response, or which patient should be treated which way? So I'm hoping that in addition to talking about LVAD, this study that Ashley is highlighting would be able to give us a first underlying principle. Could you use cell-free DNA to phenotype disease and then to monitor how patients respond to an intervention? But we'll not let non-transplant people steal the show. Let's bring it back to transplant. How about that? And then hopefully we can conclude. Remember that we had a first-generation test, which is sensitive but not specific. And then we went forth to develop second, third, and fourth generation tests that looked at epigenetic fingerprints. Histone footprinting, I didn't show that. DNA methylation, chromatin immunoprecipitation, thanks to really hard work from basic scientists like Moon and others in the lab. We wanted to bring it back to transplantation. We wanted to see, ask the basic question, could cell-free DNA epigenetic fingerprinting be a proxy for gene expression? And I think the answer to that question is yes. This is why. In our body, there's a set of genes called housekeeping genes. They're always turned on. They're always expressed. We need them to make energy, to do this and to do that. There are about 9,100 of them. We took 6 healthy controls, and the criteria for definition was that we would only say a gene is detected if it was detected in all 6 patients. Means if it was detected in 5, we would say no. 5 out of 6 now. Right? So in all 6 patients, we were able to detect 91% of all housekeeping genes. Let's take it a step further. How about now we take heart transplant patients who are on calcineurin inhibitors, tacrolimus. We ask the question, can we detect calcineurin-related genes? So you want to target now genes of a specific pathway. Can you detect that? The answer is yes. Not only could you detect that, but they are down-regulated as expected in heart transplant patients who are on calcineurin inhibitors. You could see the calcineurin-related genes all labeled here. This again, we looked at mTOR inhibitors, and you can go all that. So it seems like the major pathways in the body, depending on how much you want to sequence, right? If you sequence more, it's more expensive. But if you sequence more, you get more out of it. So, but you could detect gene expression and you could detect pathways associated to disease. But coming back to transplantation, our question to start with was, we wanted a specific test that can distinguish AMR from ACL. That's where we started. Could we use now this tissue-specific epigenetic fingerprinting to develop a specific test? The answer to that seems to be yes. This is data from a week and a half ago. It's not published yet. We did this in graft, and so hopefully, we asked Kieran Kush from Stanford to send us a validation cohort. Hopefully we'll do that. But look at this here. This is patients, heart transplant patients, stable with no rejection, acute cellular rejection, antibody-mediated rejection. And these are biopsy defined. You notice there's a patient here whom the biopsy says they have acute antibody-mediated rejection. Their donor-derived cell-free DNA was low. There was no drop in the patient's EF. The patient stayed stable. And so, there's a group of patients here, which are patients that were treated. And these patients, when you treat them, they start moving. If you collect their serial sample, it's actually an amazing dance. Like this patient here, you treat, you do the next 3 or 4 days, a week later, this dot starts moving and going back up towards this direction, back towards stable. And the degree to which it moves back and forth tells you their response to treatment. I would stop here. When I joined Hannah Valentine's lab after fellowship, if you ask me what is cell-free DNA, I'll say, oh, I know. I did PhD in basic science somewhere. I'm good at this. No, I wasn't. I would say there's short fragments of DNA that are released when cells die. But the more you study this, the more you recognize that there's just so much you don't know. Because cell-free DNA can do much more in these patients for whom transplantation seems to be the only treatment. And with that, I would like to thank the lab. We actually, if you notice, Sam is still here, and we got to take him out now after this visit, because we're always hoping the guy will come back. This is him here. We never took him out from the lab, and maybe we should say, hey, Sam, UCSF has been kind to you. Maybe we'll let it go. But I've been very fortunate to work with these people. They're not just different in where they came from, just the difference in how they think. And if you think diversity, I'm telling you, diversity can unearth things that you cannot imagine, because this group of people, they build a clinical cohort that you see here. We collect somewhere between 20 to 50 serial samples per patient over time, follow them for 10 years. All clinical endpoints are adjudicated centrally. It's amazing how fortunate I've been to work with this group of people. Allow me to leave you with where I'm from, Cameroon. It's in Central Africa. And I would tell you that if you have money, but you don't have time, if you don't have enough money and you don't have enough time, which is all of us, right? And you want to see most of Africa, you should go to Cameroon. I came from right here. It's on the west coast of Cameroon at the banks of the Atlantic Ocean, which is all the way out here. On the back of this area, Limbe, there's a volcanic mountain with black volcanic soil. Some of the beaches have black soil. And if you love fishing, you go out in the ocean, usually go around 4 a.m. Then fishes are sleeping and they eat more readily at that hour. I don't know. We go at 4 a.m. So it's dark. And then you're coming back around 6:30 a.m. The sun is rising behind you and it's hitting on that black volcanic mountain. I'll tell you, I have not seen a sight that is more beautiful than that. And of course, I'm biased. I'm from there. So I would say if you can, that would be something that I would recommend. And truly, thank you all for the very warm reception and for the opportunity to talk to you. I would stop here. And Ashley and I would take any questions. Thank you.